Today we're going to be presenting CMS Meaningful Use Relaxation Rule. What does it mean? This is the 11th installment of our educational webinar series, and we hope you find it helpful and insightful. My name is Chelsea Lukens. I'm the Marketing Communications Coordinator for Attest. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, I'm pleased to announce our upcoming webinar. On August 12th, we will be presenting Improving Patient Satisfaction with the Portal. We hope to see you there, but if you can't make it, we will offer recordings of the webinar on our website, just as we will be doing with this webinar. Moving on to the CMS Meaningful Use Relaxation Rule. At the end of the presentation, we will open the floor up to questions from you. We will answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box and let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today, Lindsay Lanning and Cynthia Kincaid. Lindsay Lanning originally joined us from the Ohio State Intern Program while she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as the Healthcare Informatics Coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Cynthia Kincaid is Vice President of Consulting Services at Attest and a Certified Practice Management Executive. With over 25 years in the IT healthcare industry and 8 years with Attest, her experience runs wide and deep. She is not only a senior executive at Attest, but she lives and breathes the industry and travels across the country seemingly nonstop working with her clients at their locations. This makes it possible for her to provide the insight needed to help healthcare organizations experience great success no matter what the challenge is. Cynthia, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Well, first of all, I'd like to thank everyone for joining today. I wanted to let everyone know that we are going to be covering the proposed rule. It is not final, and Lindsay will be discussing that aspect of it as we go through the webinar. In addition, we're not going to be focusing heavily on NextGen today. Our focus is going to be on the CMS proposed rule changes, the Medicare, and the regulatory changes. We will do our best to answer any NextGen questions, and also I wanted to let everyone know that NextGen had a very informative webinar yesterday, and we have copies of that presentation that we can also send in addition to copies of this one. So without further ado, I'm going to let Lindsay take it away, and she'll be presenting this very in-depth and sometimes very technical discussion on the actual proposed changes. So hopefully you will enjoy the webinar, and we'll answer questions at the end. Thank you, and go ahead, Lindsay.
Hi, everybody, and welcome. A few months ago, we did a webinar on the proposed Meaningful Use Flex Rule released last August, where we went over the changes made to EHR certification criteria needed for EHR reporting in 2014. Here we are, less than a year later, and CMS has released another set of proposed rules. So for today's webinar, we will primarily focus on breaking down those proposed rules and analyzing the modifications and the impacts of those modifications from an industry-wide perspective. Specifically, on the agenda today, we're going to talk about the proposed modifications to meaningful use in 2015 through 2017, clinical quality measures, proposed rule for meaningful use stage 3, and the proposed 2015 EHR certification criteria. Meaningful use stage breakdown. So stage 1, data capturing and sharing. Stage 2, advanced clinical processes. Stage 3, improved outcomes. From this overall breakdown of meaningful use, you are given the end goal of each stage. You can see stage 1 is really about setting up those basic functions of data capturing and sharing. So when we move into stage 2, we could focus on advanced clinical processes. This stage looks at and measures the enhanced performance, efficiency, and capabilities of those processes achieved in stage 1. Finally, when we get to stage 3, we shift focus to improved outcomes. This puts an emphasis on that underlying layer that makes improved outcomes possible, which involves things like population health, interoperability, coordination of care, and being able to actually share outcomes through quality reporting programs.
Hey, Lindsay, can I stop you real quick? Can you move your mic a little bit closer?
Absolutely. Is that better?
Perfect. Yep, thank you.
Okay. All right, so let's look at the first proposed rule. Modifications to meaningful use in 2015 through 2017. On April 10, 2015, the Centers for Medicare and Medicaid Services issued a new proposed rule for the Medicare and Medicaid electronic health record incentive programs, which hopes to align stage 1 and stage 2 objectives and measures with the long-term proposals for stage 3, build progress toward program milestones, reduce complexity, and to simplify provider reporting. I want to mention this information is not final and may change. It is in a commenting period now and is expected to be released in August or September of this year. Now, from past experience, we know that most of the concepts and details will remain the same or very similar, but you must understand that some things may be adjusted in the published final rule. So what's changing? Well, the modifications to meaningful use set forth by this proposed rule are it changes the reporting period in 2015 to a 90-day period aligned with the calendar year. As you may recall, many large organizations, specifically the AMA, had strong reactions to the Flex rule released last August. They wanted meaningful use requirements to be modified to have a 90-day reporting period for 2015, which CMS took into consideration and has actually delivered on. They've also aligned with the calendar year and are allowing any continuous 90-day reporting period. This means it's not tied to a quarter, but you do have to complete reporting in the same calendar year, so you can't start in December 2015 and then finish in February 2016. This proposed rule also modifies patient action measures in Stage 2 objectives related to patient engagement. I know we've all been waiting for this one to happen, and it's going to be a major improvement for everyone. And finally, it removes reporting requirements on redundant, duplicative, or top-down measures, therefore reducing the overall number of objectives. Purpose of modifications. Why are they doing this? Why change now? So the purpose of these modifications is to allow providers to refocus on the advanced use objectives and measures. These advanced measures are at the core of IoT-supported healthcare, which drives toward improving the way electronic health information is shared among providers and with their patients, enhancing the ability to measure quality and set improvement goals, and ultimately improving the way healthcare is delivered and experienced. Changes to participation timeline. So it's important to understand with these modifications there will be both participation and reporting changes made. This graphic gives a great high-level view of the changes to the participation timeline that are expected with this proposed rule. You can see in 2015, providers will need to attest to the modified version of Stage 2 with accommodations made for Stage 1 providers. So basically, everyone will be needing to attest to this modified Stage 2 unless for some reason 2015 is your first year of meaningful use attestation. Then you have those exceptions and accommodations made for you. For 2016, all EPs should be attesting to that modified version of Stage 2. There's no exceptions here. Everyone should be on the same page. In 2017, EPs attest either the modified version of Stage 2 or the full version of Stage 3. So this is what we're going to call a flex year. You have two options. And it will basically depend on your EHR certification criteria, which we will basically go over next. In 2018, everyone should be on the same page attesting the full version of Stage 3, and this will be the final stage of meaningful use. If you recall, the Flex rule published last August originally extended the Stage 3 timeline to 2017 for providers who attested in 2011 or 2012. So again, this is being pushed back to 2018. While the other extension created by the Flex rule, which mandated Stage 2 attestation by 2016, is still being enforced. So back to this idea of 2017 as a flex year. So meaningful use Stage 3 was originally slated to begin in 2017 for providers that had completed Stage 2. Now 2017 is a flex year. This means that providers who have progressed from Stage 2 to Stage 3 in 2017 now have the option to stay in Stage 2 for an additional year. Only providers who use EHR certified to the 2015 ONC standards will be allowed to attest to Stage 3. Every provider will be meaningfully use Stage 3 in 2018, even if 2018 is the provider's first reporting year. In order to simplify the meaningful use program, all providers will be in the same stage at that point. This will allow group practices to focus on a single set of measures for all providers, which I'm sure all of us are happy about. I know it's been a real pain to keep up with all the changes being made in such a short period of time. It's hard to know exactly what's expected from your practice and at which stage or which set of criteria you should be using. So this is really trying to simplify this program and get us all on the same page. So in order to help you with this, I really like how this chart allows you to pick which year you first attested to as a meaningful user and which stage you will be required to attest to each year. As you can see, if your first year of attestation was 2014 or 2015, and you were planning on demonstrating Stage 1 meaningful use in 2015, you will have alternate exclusions and specifications for certain objectives and measures. What this means is Stage 1 of meaningful use is essentially gone with additional exemptions, like I said. Stage 2 and Stage 3 would be the only meaningful use stages available for attestation moving forward. So that wraps up all of the participation changes with the proposed rule. Now we're going to go ahead and go over to the reporting period changes. So in 2015 and 2016, new meaningful use participants would be allowed to attest for any 90-day period within the calendar year. For 2015 only, eligible providers will be allowed to attest for any 90-day period within the calendar year, regardless of their previous participation. For 2016, all eligible professionals, eligible hospitals, and critical access hospitals who are first-time attesters would be allowed to attest for any 90-day period within the calendar year, while returning participants would use a full calendar year for reporting. For 2017, all providers, regardless of their previous participation, would use a full calendar year reporting period as proposed in the Stage 3 proposed rule. So I know this can be a lot to take in and dissect all at once, so to break it down for you, in 2015, EPs would be allowed to attest to an EHR reporting period of any continuous 90 days within that calendar year. For 2016, all returning participants would use an EHR reporting period of that full 2016 calendar year, whereas EPs demonstrating meaningful use for the first time in 2016 can still use that EHR reporting period of any continuous 90 days. But once we get to 2017, all providers, both new and existing participants, would use an EHR reporting period of one full calendar year. So now, having gone through all these proposed participation and reporting guideline changes, we reach the main purpose of this rule, and that's to better align with Stage 3 objectives. This will reduce the burden by creating a single set of sustainable objectives, and it will enable providers to focus on objectives that support advanced use of health IT, such as health information exchange, public health reporting, and quality measures reporting. I mean, this is the whole point, to streamline efforts and get everyone on the same page so improvements can be made through the advanced use of health IT. So what will these new relaxed objectives look like? Well, there will be a core and menu concept change. So because of the restructuring of measures, the concept of core and menu will be discontinued in favor of choices within certain objectives. The new reporting structure is outlined below. So with the current Stage 1 structure, there are 13 core objectives that providers must comply with. Then they get to choose 5 out of 9 available menu objectives. Out of these current Stage 1 objectives, 6 core objectives and 3 menu objectives are staying and will be reused in the new proposed structure, but all of them will be mandatory. So again, CMS is proposing to eliminate that distinction between core and menu objectives, and all retained objectives would be required. What this does is simplify the structure by decreasing the amount of overall objectives and making sure everyone is attesting to the exact same 9 core objectives and 1 public health objective. The removed objectives were identified by CMS as either redundant, duplicative, or topped out, and will no longer require attestation on them, and these are actually listed below. So CMS states that many of these redundant, duplicative, or topped out objectives and measures may be valuable to providers and patients, and may encourage providers to continue to conduct these activities if it suits their practice and their patient population. CMS says this because any measure that may be considered topped out just means that it is so widely met and exceeded by providers, there's no longer a need to mandate it, but if it is adding value to your practice, it is encouraged that you continue doing it. So changes to MU objectives. Changes made to objectives listed below will be effective for EHR reporting for EPs beginning in 2015, and that's to patient access objectives and public health objectives. So this is, again, what we're really excited about. These changes try and decrease instances where providers don't have control over an objective's success. So provider control can be negatively influenced by measures that rely on the cooperation of patients. They don't have direct control over what their patients do or what they're going to do, so these revisions really hone in on what the provider does and not what the patient does. Changes to patient access objectives. So the proposed threshold changed that more than 5% of patients must view, download, or transmit health information to just one patient needing to do so. The next proposed threshold changed. A secure message must be sent using electronic messaging of CERT by more than 5% of patients to just having secure messaging fully enabled. Again, taking that patient participation factor out, since it truly is out of the provider's control if this is successful or not. And that'll really help. I think it will make a big difference for those who have not been able to comply with this objective before. Also, this objective is changing to self-attestation, which means providers will be responsible for saving all the documentation needed to support attestation, such as a screenshot using a test patient in the patient portal that is dated to show secure messaging was enabled. Changes to public health objectives. Stage 2 providers are required to successfully engage in any combination of 2 public health measures, unless the exclusions less than 2 options remain. Stage 1 providers are required to successfully engage in 1 public health measure unless exclusions are met. This consolidates all public health reporting objectives into 1 objective with measure options following the same structure of Stage 3 public health reporting. So again, this gives the provider the freedom to pick and choose what best suits their practice while also aligning with Stage 3 objectives. This also is changing to a self-attestation objective as well, which again means the provider is responsible for documentation, which will be a bit extensive, especially if you're proving your practice falls under an exclusion for any public health measure. We're going to go into greater detail on these exclusions when we go over the Stage 3 public health objectives. So after all of these changes made, what will 2015 look like? This proposed rule has a 2-month comment period, and therefore we expect the final rule around August or September of this year. After the final rule is published, EHR vendors will need to update their meaningful use report cards and the measurement period options in their software. While there may be a few 90-day reporting options available, we expect another year where most providers will be reporting in the last quarter of the year. So again, kind of to recap these changes for 2015, providers will attest to a single set of blended Stage 1 and Stage 2 objectives. There will be no more core menu distinction, and all reporting will be for 90 days. So this single set of blended objectives is what we're calling the modified Stage 2. And this is done by leveraging existing objectives and measures of meaningful use. Accommodations by multiple exclusions and alternative measures within individual objectives will be made for providers who have been in different stages of meaningful use. And I wanted to touch on this. CQMs will still be reported electronically or attested to, and the CQM 90-day period doesn't need to coincide with the 90-day MU attestation period. I also want to stress, if your first year of meaningful use was in 2014 or is in 2015, you will have accommodations and additional exclusions in the proposed new objectives since you would have been in Stage 1 during 2015. So because of delayed attestation in 2015, first-time attesters that attest after October 1st will have the CMS penalties reversed once attestation is complete. Cindy, do you want to chime in here and tell us a little bit more about this?
Yes, one of the things that I wanted to mention is that we had a number of clients last year who had providers that were in Stage 1 and did not, or were first-time attesters for Stage 1 and did not achieve Stage 1. If this rule is published and approved, we are going to be reaching out to them because they will have the ability now to attest under the modified Stage 2 for the first time, and then if they successfully achieve it in 4th quarter, then the penalties will be reversed. So we're very, very excited about that if, in fact, this is approved, and it will probably require some additional explanations, but again, something that to keep our eye on if you did have providers in your practices that did not achieve it and were moving to a penalty phase.
Great, thank you. So now going back to that statement I made regarding the CQM reporting period, that 90-day period doesn't need to coincide with that 90-day MU attestation period of 2015. So I wanted to touch on the basics of CQMs and what is expected this year. So CQMs, or clinical quality measures, are still required to be meaningful user. It's not changing. CQMs are tools that help measure and track the quality of healthcare services provided. These measures use data associated with providers' abilities to deliver high-quality care or relate to long-term goals for quality healthcare. To participate in Medicare and Medicaid electronic health record incentive programs and receive incentive payment, providers are required to submit CQM data from certified EHR technology. So for 2015, EPs will need to report 9 of 64 possible measures. These 9 measures must cover at least 3 of the 6 national quality strategy domains. And these domains are patient and family engagement, patient safety, care coordination, population or public health, efficient use of healthcare resources, and clinical process or effectiveness. So next-gen users, our CQM reporting tool is next-gen HQM. A lot of people are asking what's the plan for next-gen HQM reporting when and if the 2015 Stage 2 proposed rule is finalized, and will next-gen modify the HQM reports to accommodate these changes? The answer is yes. The program for the objectives should be available within a few weeks of the final rule, in addition to any changes to the code for the objectives, if applicable, and of course threshold updates. So we were also notified on July 27th an HQM 3.8 automatic upgrade will take effect, and it features a new de-identification tool which improves secure data encryption and transmission to accelerate report submissions for meaningful use in similar programs. So current next-gen HQM users should upgrade their client-side service as soon as it's available after July 27th to ensure and maintain meaningful use readiness. If you need help understanding more about CQMs for 2015, or if you want to see any CQM samples, they are available on the CMS website. Right now we're going to go ahead and switch gears from the proposed modifications to meaningful use for 2015 through 2017. So look even farther ahead at the proposed meaningful use Stage 3 rules. So proposed rules for meaningful use stage 3, broken down by notable objectives. I want to reiterate that this information is as well not final and may change. It's in a commenting period now as well, and it is expected to be released this year. So a CMS official reported with stage 3, the goal was to become simpler, to get to something that was sustainable for future achievement, to focus in on areas that were priorities for us as an agency, but also for us as healthcare providers and consumers, promoting health information exchange, and focusing on improved outcomes. So the main goals laid out for stage 3 are increased data interoperability, advanced use of EHR technology to improve patient engagement and coordination of care, and improve program efficiency, effectiveness, and flexibility by aligning the EHR incentive program with other CMS quality reporting programs. If we think back on the main goal of the proposed modifications to MU 2015 through 2017, it was to align stage 1 and stage 2 with meaningful use stage 3. Now here we are, we've come full circle, and Meaningful Use Stage 3's main goal is to align the entire Meaningful Use program with all other CMS quality programs. So again, there's this idea of streamlining and getting everyone on the same page for the next few years, which I'm pretty sure everyone can be excited about. Meaningful Use Stage 3 criteria focus. It's on improving quality, safety, and efficiency, leading to improved health outcomes, decision support for national high-priority conditions, patient access to self-management tools, access to comprehensive patient data through patient-centered health information exchange, and improving population health. The proposed Meaningful Use Stage 3 includes 8 objectives, but some objectives are subdivided into multiple measures. Therefore, providers will need to attest to approximately 16 measures. So the retained Stage 2 objectives with modifications include protecting electronic health information, e-prescribing, clinical decision support, and computerized physician order entry. Objectives with expanded scope include patient access to health information, coordination of care, health information exchange, and public health reporting. So the retained Stage 2 objectives with modifications will be shown in the next slides with the modified Stage 2 objective and measure on the top in a green box, and the proposed Stage 3 objective directly below it in the orange box. This will show you how similar the objectives and measures are, with only slight changes being made. Then the modified Stage 2 objectives that are eventually combined together to form a single Stage 3 objective will be shown next, followed by the proposed Stage 3 objectives. I want to preface that this is a, yep.
Can you slow down a little bit?
Yep, absolutely.
Thank you.
Yep. So I want to preface that this is a ton of information to digest. So instead of reading through each objective, I'll just be pointing out notable differences since we'll be providing copies of this presentation to everyone. So let's get started. So protect electronic health information. If you look at these top and bottom, you can see they will be staying essentially the exact same in Stage 3 with virtually no differences to note from the modified Stage 2 version. This idea of conducting a security risk analysis is something we're all familiar with already, and it will be sticking around. Electronic prescribing. So you can see here, these are again the exact same objectives and measures. The only difference being the percentage increase from more than 50% to more than 80% of prescriptions are required to be transmitted electronically in Stage 3. There's also this exception we will see a lot. If you write fewer than 100 prescriptions in this case, or if you're performing fewer than 100 units of service, you do not need to comply with this measure. So clinical decision support, again, here we are. We're seeing that these will be the exact same for modified Stage 2 and Stage 3. We also have that less than 100 orders. It's that exception that keeps popping up for that measure 2, and it's making an appearance. You'll see this. There's 2 separate exceptions that we'll see here. It's at 100 threshold, and there's also a 0 threshold where if you've had no visits, which is coming up next. So computerized provider order entry. Here there is a few changes to point out. First off, the Stage 3 objective adds in criteria that clarifies who exactly can perform CPOE specifically, while also increasing the percentages from more than 60% to more than 80% medication orders and more than 30% to more than 60% of lab and diagnostic imaging orders. Stage 3 also clarifies what exactly diagnostic imaging includes instead of just leaving it as radiology orders, which you can see listed below. It includes ultrasounds, MRIs, CT, and other diagnostic imaging. I want to point out here there are some specific features to NextGen that really help the user achieve this meaningful use objective. And Cindy, if you want to go ahead and elaborate on that feature.
Yes, and as I mentioned earlier, we do have copies of the next-gen presentation, but this probably wasn't covered. As you know, now they're looking into who is actually providing a next-gen, and their system administration file maintenance allows this to be set up at the provider itself. And basically what that means is that you can determine if they are a credentialed provider or a non-credentialed provider, and that will actually help you as you're keeping track of this and managing these measures.
Perfect. Thank you for that. So patient electronic access to health information. So if you compare these, you can see differences again in an increase of percentage from more than 50% to more than 80% of patients needing to have access to their information, as well as a stricter time frame required. You're going from 4 business days to just 24 hours of its availability to the provider. There's also now this option of using an API for Measure 1, which CMS seems to really be pushing in this stage. We will see it pop up in multiple measures. And finally, the most subtle change, I think, is the increase in broadband availability. It's actually going from 3 Mbps to 4 Mbps in that Measure 2 exclusion. Also, to point out, patient-specific education, which is a Stage 2 modified objective, is included in this Stage 3 objective, and it increases from more than 10% to more than 35% of patients must have access to patient-specific education resources. So like I said, these ones are the ones with modification, not expanded scope. This is really just about kind of going from modified Stage 2 to Stage 3 and beefing up those measures and making it a little bit more difficult. So summary of care records. So starting from here on out, we will see these next few modified Stage 2 measures. They're kind of lumped together under different Stage 3 objectives, which is the reason behind the overall decrease in the amount of objectives in Stage 3. If you remember, I said that there may be 8 objectives, but there's still 16 measures that you're actually going to have to attest for. So it kind of are lumped together and funneled into one. So we will see these new Stage 3 objectives in the following slides, and it'll all kind of come together neatly at the end. So back to summary of care record. This is concerned with creating and transmitting the summary of care for more than 10% of transitions of care. And again, it has that exception of if you did less than 100 transfers, there's no need to comply. Now, this objective will be found under the new Stage 3 objective, Health Information Exchange, which will come later. Patient-specific education. Patient-specific education needs to be provided to more than 10% of patients. The exclusion here does not use that 100-unit threshold, which I had mentioned previously. It just says if you have 0 office visits at all during the reporting period, then you are excluded from this measure. This objective will be carried over and found under the new Stage 3 objective, Patient Electronic Access to Health Information, which we actually went over 2 slides prior to this and I had mentioned. So medication reconciliation. Medication reconciliations need to be completed for more than 50% of transitions of care that you receive. Similar to our last exception, if you are not the recipient of any transitions of care in the reporting period, then obviously you don't have to worry about this because this does not apply to you. This objective will be retained, and it will be found under the new Stage 3 objective, Health Information Exchange. Secure electronic messaging. So finally, this is the last modified Stage 2 objective we have, and I mentioned this change to just having secure messaging fully enabled earlier and not having a specific threshold of patients needed to comply with this, and how great of an improvement it is taking out that patient participation factor and going back to just having it fully enabled. So this measure will be addressed in the proposed Stage 3 objective, coordination of care, and it does actually go back to a threshold. So now we're going to go ahead and transition to these new proposed Stage 3 objectives that I mentioned in the orange boxes before. These objectives are considered to have an expanded scope for Stage 3 versus just the slight modifications, which we were just looking at. So here's where we start kind of pulling it all together and tying up those loose ends. So Stage 3 objective number 6, coordination of care. Like I said, you'll see this is the next few Stage 3 objectives. The 2 Stage 2 objectives were kind of funneled into that one with multiple measures. So this Stage 3 objective covers both secure electronic messaging and coordination of care. This changes the secure messaging from just being fully enabled to requiring more than 35% of patients be sent a secure message. So like I said, we have that simplification of just having it fully enabled, but we go right back up to having that threshold of more than 35%. It also requires more than 25% of patients to actively engage with the EHR instead of just one single patient. Now, when I say actively engage in this instance, I mean view, download, or transfer their health information. Because actively engage will be a key phrase we'll talk about later. Stage 3, Objective 7, Health Information Exchange. Again, you see this pattern of combining modified Stage 2 objectives, summary of care record, and medication reconciliation into one Stage 3 objective with multiple measures addressing those each. You can see there's an increase from more than 50% to more than 80% of medication reconciliations must be completed, while also adding in allergies and the current problem list to be reconciled as well. This also increased the percentages from more than 10% to more than 50% of transitions of care where the EP needs to create the summary of care record and exchange electronically. Lastly, we have the Stage 3 objective number 8, public health reporting. This is also a modified Stage 2 objective, except you are only responsible for attesting to 2 measures instead of 3. So it's the exact same objective and the exact same measure, it's just decrease the amount of measures you actually have to comply with. So the EP, here's that key phrase, is actively engaged with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using CERT, except where prohibited, and in accordance with applicable law and practice. The proposed measures, the EP is required to successfully attest to any combination of 3 measures from the 5 available. So you can see on the left-hand side, the reporting measures available are shown, and then on the right-hand side, it's the maximum number of times the measures can count towards an objective. So you can do any combination of these, which leaves the provider some freedom to choose what best fits their practice. If you did do 2 public health registry reporting, for instance, it would need to be 2 different registries, such as birth defects and cancer. And I know that's not a likely scenario, but you kind of get the idea here. So for Stage 1, like I said, you must attest to 1 measure, Stage 2, 2 measures, and Stage 3, 3 measures. There are exceptions to this if for some reason your practice cannot attest to that many for reasons outside of your control. And we'll talk about this as we look at what specifically actively engaged means in this proposed objective. So active engagement. Active engagement is defined as option 1, completed registration to submit data. So this means that registration was completed within 60 days after the start of the EHR reporting period, and the EP is awaiting an invitation from the PHA or CDR to begin testing. Option 2, testing and validation. And what this means is the EP is in the process of testing and validation of the electronic submission of data. EPs must respond to requests from PHA within 30 days, and a failure to respond twice within a reporting period would result in a failure to meet this objective. So if a PHA ends up reaching out to you and asking for more information or says we need more validation or testing done and you fail to respond, this will not count towards your meeting this objective. Option 3, production. An EP has completed testing and validation and is electronically submitting production data to a PHA or CDR. Earlier I mentioned exceptions for practices if they couldn't meet the number of public health measures required because they may not have enough options. This means that if you are unable to report to a registry due to a reason out of your control, like all of the registries are closed for meaningful use reporting. So after the start of the reporting period, you must register your intent to report within 60 days. If you don't have registries that are capable of accepting the information or have not declared readiness, you will be able to be excluded from this measure. As of now, from what I know, there aren't any states that have declared readiness or not, but also I think a lot of people are waiting until this is actually finalized. Another reason for a valid exclusion would be that your measure is not appropriate for the clinical scope of your practice. So meaning you do not treat or diagnose any disease associated with the registry, or for instance, you don't administer immunizations at all. So with either of these, you can opt out, but it just doesn't count towards your number of measures you have to complete. This does mean you need to look at other options to meet that number. So the only way to get excluded from them all is to literally go down the entire list and say why you can't do each. So for example, if an EP in Meaningful Use Stage 3 has a valid exclusion for 2 measures, they still must complete the other 3 measures available. You will only be excluded from fulfilling the full number of measures, depending on what stage of meaningful use you're in, unless every option is exhausted. So to only attest to 1 measure in Stage 3, that would mean you have a valid exception for all 4 other measures. Now what I want to stress here is that it is the responsibility of the provider to retain all evidence that that objective was met, which includes all the documentation that supports an exclusion. Don't assume based on your specialty that as a provider you don't need to collect information. Make sure you're doing your homework. Check with your state for any reporting opportunities. If you are a specialty practice and you don't know where to find this information, contact your specialty society and determine if it's available. So again, I want to reiterate, make sure you're doing your research and keep any documentation of your efforts for future audits especially. So kind of bringing it all together nicely here, we have the proposed objectives, modified stage 2 versus stage 3. So this chart shows you the modified stage 2 objectives side by side with the proposed stage 3 objectives. And it's a great visual to really see how this modified stage 2 version feeds directly into stage 3 and becomes a more compact and condensed version. You can see objectives 1 through 4 are exactly the same. And then the remaining stage 2 objectives are kind of coupled together like we went through and saw to decrease the overall number of objectives in stage 3. I want to stress, if you're one of those providers that is attesting for meaningful use for the first time in 2015, going through all of these earlier, I kept talking about these additional exclusions that providers were scheduled to attest for. You would still receive them. And in reality, almost every single one of these proposed modified stage 2 objectives and measures gives a provider an option to either attest to the current stage 1 objective they were already planning on doing, or reduces the threshold, or basically they are completely excluded from an objective that may have been a menu objective they weren't planning on attesting to in the past. So what can you do to prepare your practice? These rules are not yet final and definitely could change, but there are still some things you can do right now. So don't forget about the deleted measures. Continue to monitor them and utilize them because they impact other measures and CQMs. Run stage 2 reports for all providers, even those in stage 1 for 2015. This will identify gaps and workflow issues to meet the modified stage 2 objectives. Start planning now. Be prepared, but understand the changes discussed today are proposed and won't be final until August or September, and thresholds and exclusions may change in the final rule. You can also get educated on topics. You can sign up for emails from CMS for alerts when final rules are released. You can get started on your security risk analysis. That's not going anywhere. We talked about that. You still have to do this every year. You can also start looking into public health reporting opportunities and begin the process of registering your intent to submit data and kind of doing that research and that homework that we talked about. Also, finally, make sure to keep in contact with NextGen or any other vendors that impact your meaningful use reporting for any updates they have out. All right, the last proposed rule we will go over today is the proposed 2015 EHR certification criteria. And this is kind of broken down by notable changes. So the proposed 2015 EHR certification criteria, the new proposed EHR criteria incorporates elements of the 2011 and 2014 editions, and it aligns with the ONC's draft nationwide interoperability roadmap that calls for expanded use of interoperable health IT by 2020. The 2015 edition includes provisions that address certification criteria to support population health management, interoperability, which is a key word in this proposal. It's a lot of what people are focusing on for these standards, data portability and access, improved transparency, and enhanced privacy and security capabilities. So there will be changes, and these changes will be to the criteria for transitions of care. It'll be highlighting this difference between content and transport for more opportunities for health information exchange entities to certify transport capabilities. It will adopt a new minimum standard code sets. So ONC proposes to adopt newer versions of the 4 previously adopted minimum standard code sets. And these are the most up-to-date versions of SNOMED, LOINC, RxNorm, and the CVX code set. It also proposes to adopt 2 new minimum standard code sets, and that is National Drug Codes and the Centers for Disease Control and Prevention's Race and Ethnicity Code System. There will also be a discontinuation of the complete EHR definition. So this shifts focus to highlight the EHRs with capabilities needed for the specific meaningful use stage to which each provider is attesting. So that'll be different. It'll kind of be scaled down a little bit. Now, I do want to point out again that in 2017, providers may use EHR technology that's certified using the 2014 edition or the new proposed 2015 edition. That's our flex year. But for the reporting period in 2018, all providers must use an EHR that has been certified with the 2015 criteria, so this new proposed criteria that will be coming out this year. Okay, so version and criteria. So if you aren't sure what criteria your current EHR is, if you are a NextGen user, NextGen EHR 5.8 was 2014 edition certified as a complete EHR on March 1st, 2016. And then NextGen Healthcare was among the first of 3 EHR companies in the nation to earn the ONC HIT 2014 edition certifications. So I think that should be pretty comforting information in light of this new 2015 criteria that's expected to come out. So if you upgraded to version 5.8, it follows 2014 EHR certification criteria. And some people were wondering this could not be back certified with 2011 EHR certification criteria. But honestly, all clients should be using 2014 EHR certification criteria because 2011 is essentially gone. 2015 EHR certification criteria, again, like I said, will be mandated by 2018. And then before we wrap up here, I did want to mention that the CMS website to attest is not available and will not be up until the first quarter of 2016. So I don't want people to head there and start looking for things and then have it basically not be up until we're not sure. We've heard January 1st, but it could be a little later than that. So questions. We're going to go ahead and open it up. I wanted to thank you all for listening to this presentation. There will be more to come regarding these proposed rules, especially when the final rules are released.
Hi, everyone. Just a reminder, you can type your questions
Thank
in
you.
the question panel of the GoToWebinar pane. And so go ahead and type those. And Cynthia, I think you had some things you wanted to add.
Yes. First of all, thank everyone for attending. This was a lot of information and a lot of variable rules, regulations, and how to present those entertainingly is always a challenge. We did go a little fast today because, as you can see, there's a lot of information in this presentation, and when we practiced it last night, we were running long, so we probably got a little carried away, but wanted to leave time for questions and answers. Everyone is going to get a copy of it either from our website and with the recordings that we publish and the links to our website, so hopefully if you did miss some things, you can get through it. We're also going to answer your questions the best of our ability. Lindsay has spent an enormous amount of time researching this. We've been working on this presentation really since these rules were published, and we have done our best to disseminate them. We are not meaningful use experts. We'll give you our best answers that we can. And when I say meaningful use experts, we've really worked hard at it. I think we're giving you valid information. With that said, you always want to make sure that you check with your own specialty agencies, MGMA, CMS, and all of the areas if there's something we're not certain about. If we don't know the answer today, we will go back and research it. And with that, we'll take the first question.
Okay, first question. Will the proposed new objectives in 2015 also apply to returning providers, not new providers to meaningful use?
Yes, this is a proposed rule that is a relaxation for everyone.
Okay, next question. For the patient education, if we are, if we are in a 90-day reporting period, can the patient education be given at any time in the current year, or must it be within that 90 days?
As far as I'm concerned, taking my interpretation of the rule, it does need to happen within that 90 days.
That's my understanding as well.
So to clarify, if all of my providers have attested previously, they will attest to the modified stage 2 any 90 days this year, and we stay with the modified stage 2 for the year reporting period in 2016, and then we can choose to stay with the modified stage 2 again in 2017?
Yes, this is correct. So the only change you will see between 2015 and 2016 will be that reporting period will shrink, or will actually grow back to a full year. So you can stay in that stage as long as you want till 2017, but for 2016 and 2017, your reporting period will go back to a full calendar year. That flex year depends, if you go to stage 3, depends on your EHR certification criteria. So if you're still on that 2014 criteria, you will stay in the modified stage 2. If you actually switch to the 2015 criteria, you will be able to attest to stage 3.
Okay, great. Next question. So if I have a provider who is attesting for the first time in 2015, he is able to attest for the modified 2015 rules for his first year of meaningful use, or does he still need to do stage 1 for his first year?
So this is what I was talking about, those kind of exceptions that will be made in those special accommodations. I didn't include those exact objectives, but they are available online. Basically what they're saying is that he should still be on track for meaningful use stage 1 this year, and those are what those exceptions are. So a lot of it will be, they'll have objectives, and either they'll have the option for most of them that I've been seeing is that they'll allow him to just go back and do the current stage 1 objective he was planning on doing, or it will lower a threshold, or let's say it was a menu objective that was retained and maybe the provider wasn't planning on attesting to that menu objective, they will actually be completely exempt from that menu objective.
And there's actually clarification to that question, Lindsay. So as clarification, can he attest to stage 2 for his first year?
He will be attesting to the modified stage 2, yes. It will be the modified stage 2 with accommodations made for meaningful use stage 1, the first time attesters. That's kind of it. But yes, it will be considered that modified stage 2.
Okay. When the measures call for full year of reporting, does this exclude a provider from submitting if they are not employed for a full year?
I don't know the answer to that question. We would have to look that up. I would think there's got to be an accommodation if they're not employed.
Okay. Next question. So if you have not done stage 1 and don't intend to attest in 2015 and plan to attest in 2016, do we have to meet stage 2 requirements?
Yes, by 2016.
Yeah, go ahead.
By
go ahead.
2016, yeah, no problem. By 2016, that's kind of the whole point of it, is that there will be no more exceptions. That they're just trying to have that 1 year. I mean, we're not sure right now. The proposed rule is having some pushback on that, so we'll see with the final rule. But as of right now, correct, it will be that modified stage 2, and there will be no exceptions.
Okay, next question. Can you please elaborate, or can you repeat or elaborate on the proposed reversal of the 1% penalty in 2016 for not attesting in 2014?
Cindy, did you want to go ahead and take that one? That's the kind of the reversal of the penalty.
Well, again, as I understand it, and the question's phrased a little bit differently. As I understand it, if you have received a penalty letter for not attesting to stage 1 in 2015, which was the final year was 2014. So then basically you would have started receiving your penalties, and you would have received the letter if you didn't achieve it by third quarter of 2014. My interpretation of this, and the way that we have, we've had a couple of discussions about this, my interpretation of this is that you will now be given the opportunity to attest at a stage 1 level using the modified stage 2, again, if this is approved, and they are going to make an exception to allow you to do it in the fourth quarter of 2015, this year only. And that will then, if you achieve that, you will then be able to reverse the penalty. I don't know if there's any reversals, and again, I could have missed it. I haven't seen anything, and we'll certainly look it up, but just in case the question is coming, I don't know if there's any reversals if you had, say, attested at stage 1 and you were prepared to attest for stage 2 and you didn't meet those criteria. I haven't heard of any reversals on that. The only thing I'm aware of is the stage 1 first-time attestees, if I'm saying that properly.
Okay. Thank you, Cindy. Next question. So if the certified EHR has the capacity for stage 3 in 2017, we have to attest stage 3 versus modified stage 2?
You don't have to. You do still have the option. You will only be allowed to attest for stage 3 once your EHR follows that 2015 criteria. But no, you will have the option to, and as I'm assuming most providers will, stay in that modified stage 2 in 2017.
Okay, thank you. Next question. So if we have attested in stage 1 last year in stage 2, then this year we report for a full year.
If the flex rule is proposed, if the flex rule is passed, then you will be able to attest for a 90-day period using the modified stage 2 objectives. So basically, that's the purpose. There's so many people trying to attest full year. A lot of our clients I know that we've been talking to are counting on this. I believe confidently that the 90-day attestation period is going to be approved. I'm very, very confident about that. I'm not as confident that they won't make changes or make some of these relaxations perhaps a little more challenging. A lot of groups are relying on that, but technically speaking, if you're following the rules as they exist today, you would be attesting for the full year if you had attested at stage 2 for 90 days last year. In the event that it's passed, you would no longer have to be required to do the full year. So let's say that you're in board, you've got your full year going, everything's under control, then you really don't have an issue. If you haven't done it, then this is going to give you the relaxation. And I will find that most people, particularly with the patient engagement measures, were really challenged in making these numbers this year. I'm confident that the 90 days is going to go through and that you will only need to attest for 90 days. And it can be any 90-day period if, again, it's passed. And I want to emphasize that. If it is passed, then it can be any 90-day period. So it could be January, February, March, April, May. Again, you can just go through any of the periods without adhering to a specific calendar quarter.
Okay, next question. Will the provider have to attest for stage 2 this year, even if they only first attested to stage 1 last year?
No, so that's kind of, to jump on that chart that I had shown, the second one down, that kind of took you by the first year you were a meaningful user. For 2014 and 2015, it did have those stars next to it, so there would be certain accommodations. Those accommodations are available, I think most of them online now and are in a comment period. So I'm pretty sure that there will be exemptions made for you as well.
Okay, next question. You mentioned a provider that missed stage 1 can now attest. Does that apply even if they have already received the penalty letter?
Yes, that even if they've received the penalty letter, even if they have received the penalty letter, then they would be able to undo that, for lack of a better word, if they successfully attest using the modified rule in fourth quarter.
Okay.
I think it's important to note. Yeah, I think it's important to note as we're kind of winding down too that this rule isn't even going to be until the end of August or September. So the bottom line is, as Lindsay mentioned earlier, we fully expect that the majority of people will be attesting fourth quarter. That is going to be the quarter they pick, because you're really not going to even know what your requirements are until this rule is published.
Okay, well, that's all the questions that we have right now. We're going to stay on the line for a couple more minutes. If you have any more questions, feel free to type them in, or else both Lindsay and Cindy's information is showing on the screen right now. Feel free to shoot them an email. Tomorrow I will be sending out emails to everybody who attended with a link to the a link to the recording and the slides. And so you can also reply back to my email if you have questions or think of them then. We're really here to help, so feel free to let us know. Follow us on Facebook, social media, Twitter. We always announce tech tips on Tuesdays, and we announce all of our upcoming webinars and other events that we might have going on, so it's a good way to stay in touch with us. That way?
Right. Well, one other thing too, now that we've added Lindsay to our team, the consulting team at Attentive, one of the things we've done is we're participating in all of the Twitter feeds and everything for CMS and many of the other governmental organizations, and that's our sole focus, is finding out this information and being able to be one of the leading individuals when we find out. So as soon as we know about the rule, we will be sending out emails, and we will schedule another webinar with the final rule similar to this one. And we'll go a little slower next time because maybe it won't be so long.
Yes, hopefully there will not be that much information.
Okay, everyone. Well, thank you so much. I appreciate all of your time and hope that you found